took on himself the commitment to accept a scientific, social and moral leadership role in achieving this role. Now IDR has adopted this goal and this role, and we have established the Ideal Gohira and Ideal Gohira network, which has been very active and has had a very good workshop here in Dubrovnik just 2 days ago, and we have come up with several papers which lay out and describe to all of us and to all of you what we intend to do and in order to achieve this very important goal of reducing and even eliminating inequalities in oral health. I want to at this point mention a pretty old article from 1980, which I always use since I've been in the area of dental public health, and I teach to all my students. It's so old that it's already yellow and almost falling away, but I've sort of managed to Xerox it and sort of keeping it alive. But this was an article by Jean Frazier and Alice Horowitz, which they published in 1980, and it lays down, among other things, five major premises for planning an oral health promoting program. The first is that primary prevention should always be the foundation. That's sort of the only axiom. That's taken for granted, it's given, and it's out there. And nobody sort of contests that or argues that. The second is that people who implement public health programs should be conscientious, ethical, and flexible. And they should be willing to accept new scientific evidence. Scientific evidence is, sometimes it seems very obvious, but the scientific evidence changes. And many of us, especially in community programs, seem to be doing things that long ago we know are not that ethical. And we need to be conscientious, ethical, and of course flexible to accept new evidence and follow new avenues and new directions in order to have a tangible effect on our communities. All our recommendations must be evidence-based. This is of course obvious to everybody in this room, but it's not always obvious in practice. And that's why this is so important to always remember and stress. Planners must be accountable. We are not always successful in what we do, and we should be accountable, and in fact we should publish and show people, even when we're not successful, not only when we're successful. And finally, communities vary. I'll give you a few very brief examples of programs, and you will see that the communities are different. They're very different, in fact. And we have to find ways to adopt and adapt our programs to the different communities that we work with. Horowitz and Fraser also made 5 steps in the planning process, which I always like remembering and putting in front of myself and my students and my colleagues. The first step is to collect all information, all data, to specify goals and objectives. The third is to identify barriers. There are always barriers, and we have to think about the barriers in advance and think in advance how to overcome them and what potential strategies we can employ in order to overcome the barriers. There always are barriers in public health. Then of course we have to implement and monitor, and finally to evaluate. So what should be the key elements based on everything I've just said to you in the prevention and management of caries? It's pretty simple. The number one method and element is fluoride toothpaste. Fluoride toothpaste is undoubtedly and inescapably been established as the best method, or at least one of the best methods, along with water fluoridation, of preventing caries. And fluoride toothpaste has been intensely put under scrutiny by the Cochrane database of systematic reviews, and they have clearly established that children who brush their teeth at least once a day with a toothpaste with fluoride will have less dental decay. That's beyond argument. And then they explain about what tooth decay is. I'm sure I don't have to repeat that to you. But they found that children aged 5 to 16 using fluoride toothpaste have less caries after 3 years of use, regardless regardless of whether their drinking water was fluoridated or not. So that's beyond a doubt, and that's been very clearly established, and that is the gold standard that we have to remember and employ. The second issue is toothbrushing. Now, as far as toothbrushing is concerned, there's much less evidence in schools or anywhere else. However, again from Cochrane, I copied this out from the Cochrane database, it is obvious to all of us that good oral health is dependent on the establishment of key behaviors, which include toothbrushing with fluoride toothpaste and controlling sugar snacking. And primary schools are a perfect basis or venue for adopting this type of intervention. However, we should note that they only found 4 adequate studies, and of this 4, only 1 was optimally adequate. We'll come back towards the end of my lecture on the problematics of this way of looking at data, but according to Cochrane, this is the way that they look at data. That one study that was adequate did indicate that toothbrushing prevented caries, but they could not conduct a meta-analysis. But the 3 studies which reported plaque outcomes all found a statistically significant reduction in plaque, and so the overviewers continue to say that good oral health is dependent on key behaviors which include toothbrushing. But again, there's not adequate evidence or good enough evidence, we are aware of that. But then there's nothing sort of else which is better than these 2 things which I've just mentioned to you. When we reach the discussion, of course, if anybody disagrees, you're welcome to disagree with me. And so I'd like to show you 3 examples of 3 programs in 3 very different countries in the world. The first country is in Scotland. You've heard a lot about the Scottish Child Smile program, and I expect that most of you know about it, so I won't go into it in detail. Lorna McPherson has presented it very eloquently at this conference, and unfortunately she's not here with us today, but we had a very exciting overview of hers on the Child Smile Scottish program, which is a very exciting and good program. The Child Smile program is available throughout Scotland. It is comprehensive. It is a holistic approach. It provides dental care combined with health care to children in Scotland. They are all provided with a dental pack which contains a toothbrush, a tube of 1000 ppm fluoride toothpaste, and an information leaflet. And they are instructed how to brush their teeth and supervise toothbrushing in the schools throughout the country. Every 3- and 4-year-old child who attends nurseries in Scotland is offered daily supervised toothbrushing. The program, as I said, is holistic. It includes healthy living, teaching children an important life skill. Please note that many of these themes will repeat themselves throughout the 3 programs that I'm going to speak to you about. Children in nurseries and schools will be offered healthy snacks and drinks as part of national initiatives for schools to improve dental health and help prevent obesity. So it's not only teeth that they're looking at, that we are looking at, it's the whole body, and the whole life of the child. They have an intense research program, which again was presented by Lorna McPherson. It's operated by funded by the Scottish Government and based at the University of Glasgow. Their aims are to determine whether the program can improve health and oral health, whether it can reduce inequalities, which is very important to any of us who are concerned with GOHERA, reducing inequalities in oral health. And if so, very important, they are trying to determine which components of the intervention, because there's a pretty wide range of interventions, which components are responsible for the best sustained improvements. So that's pretty nice, and it's a good way of looking at things. And they have published a few papers. The most recent one that I found was published in the Journal of Dental Research. which clearly demonstrated that there has been a major improvement in the dental health and dental health inequalities of 5-year-old children in Scotland over the past decade. And the trend is likely to be due to in a large extent, to the Child Smile program across Scotland. Even though the actual determination of the reduction in caries has not yet been shown statistically to have occurred. But in general, the results have been very optimistic and optimal. So that is the program in Scotland. The second program I'd like to mention to you is that of the Philippines, which is of course a very different country to Scotland. In the Philippines there's a program called Fit for School, which again is based on, again is holistic, broad range of health promotion issues. It is again funded by, it's a non-governmental organization, but it's throughout the Philippines, and it promotes a simple and cost-effective essential healthcare package again in public elementary schools, preschools and daycare centers. Here we have three components. The one is hand washing, the second is toothbrushing, and the third is a biannual deworming activity. So again, it's pretty holistic, includes various issues of health importance which were found to be important in the Philippines, and dental health was a core component. Fit for School has achieved worldwide success and has resulted in markedly improved health outcome indicated at an extremely low cost, which is very important. The program can be implemented in almost all schools, even in under-resourced locations. So it's very important for those countries in the world, or within those countries where they are developing areas which cannot afford expensive programs. It's a very simple program. You can see supervises children to brush their teeth with a good toothpaste daily. And they have a monitoring system which has been developed to identify bottlenecks. Again, remember what Fraser and Horowitz said, a potential barrier, and how to overcome it. And they also have an impact evaluation which looks at the evidence supplied by the program and how they are affecting the child's health, educational performance, and behavioral change. Behavioral change, remember, is also a central component that will repeat itself in the third program that I will mention. The Fit for School has also been published in the BMC Public Health, and in short, the conclusion states that despite only a 1-year observation period, the study found a reduction in the prevalence of moderate to heavy soil-transmitted ailments, which are worms, infections, a rise in BMI, and a reduction in dental caries. Even though, again, statistically non-significant, because 1 year is a very short period. And then finally, the third program that I'd like to present to you, and I think you haven't heard of, is a program called Smiles, and it's from Israel. And this program starts at 6 months, and it's up to the age of 5, which is the whole preschool period. Started only a year ago in Israel, and it's been wider and wider performed in Israel. Smiles is in Hebrew called Chiyuchim, and that is the logo. And this is the puppet, the dog puppet that comes together in the package. The puppet tries to encourage the children to brush their teeth, even though he seems to have human teeth, and all the children are very amused that he doesn't have proper dog's teeth. And then we say to him, it's only a dog, it's only a doll, it's not a real dog, you didn't notice. So there's a lot of fun involved. It's a fun program, and it's holistic, and it's about happenings and interaction and experiences, and among the whole package, teaching the children to brush their teeth. So we're back to the beginning. The program is coordinated by my colleague, Dr. Yuval Vering, who I'm happy is here in the room with us. We have 8 hygienists. We have a scientific planning, monitoring and evaluation system which is done by our department at the Hebrew University Hadassah. And we are working with a huge team of people, the same as Child Smile and Fit for School, institutions, BF, JDC, WITSO, the Israel, most important, the Israel Ministry of Health, and the Israel Ministry of Education. You can't and you shouldn't do anything without the government. So our goals are prevention and reduction of dental caries among infants and preschool children. There are two groups. Integration of daily toothbrushing in the life skills of infants and preschool children. Provision of the same skills to the parents and the educational staff. Enhancement of supportive environment in infant care centers and kindergartens. It's very simplistic. We try to tell them that if the mouth is healthy, which is not difficult to achieve, the whole body will smile. We try to tell them that we should start from the beginning because the beginning counts. We try to say that oral health is an integral component of general health. Children with healthier mouths will be healthier, they will have more friends, they will be more successful in learning, they'll be more successful at a later age in finding jobs and in finding dates and life partners. Now, if you notice, there's nothing here about dentin, enamel, what causes caries, and what plaque is, and what's cardiogenic foods, and why you shouldn't eat sugar. It's a very holistic approach, but it's very similar, again, going back to Horowitz and Frazier, we believe that conscientious people, and we try to be conscientious, should accept new evidence, and we know that the traditional dental knowledge education is not very effective, and we try to therefore create, based on child smile and fit for school, an environment and an atmosphere that will promote dental health. So briefly, the 6 months to 3 years, which is a very small program at the moment, it's a 3-year pilot study, and we have in 10 towns, 30 infant daycare centers, 1,000 children. We meet with the educational staff, we meet with the parents and children, have interactive happenings, and we monitor and evaluate. The bigger program that we have more experience with already is 3 to 5 years, where again with the 3-year pilot program we have here 8 towns, 180 kindergartens and 6,000 children. Here the program is slightly more structured, but it's similar. I mean, we have interactive happenings and brushing of the teeth in the kindergartens. Otherwise, it's pretty similar to the previous group. You can see here the life skills enhancing together with a doll, and just getting to know the doll and play with the doll and look at him and they speak to him, and he speaks back via the hygienist, who actually shows them how to brush their teeth. Now we have a subgroup which is supervised toothbrushing, where in 4 kindergartens we have started a daily supervised toothbrushing program with specific guidelines and instructions and supervised by the Ministry of Health. 4 other kindergartens serve as controls, and we've adopted much of this system from Child Smile in Scotland. Here you can see the kids brushing their teeth and being pretty happy about it, even though they're not smiling. And the kindergarten teachers handing out the brushes, according to every brush is the name of a child. It's all regulated and monitored. We monitor it, we've established a baseline. We have the emphasis on toothbrushing skills, satisfaction, compliance, early childhood caries. Of course, we do not have data on early childhood caries yet because it's very new. We have no publication to date, but we will evaluate and publish, I hope, in the near future. Now, the second and last part of my talk, I want to ask how can and should we evaluate community health promoting programs? Because as I said earlier, even if it's a good program, it's not easy to evaluate. And if you're looking at something as simple as toothbrushing in schools, the Cochrane comes out with these conclusions that we don't have enough evidence, which is true. So according to Cochrane, the gold standard is the randomized controlled trial, which is considered as providing the strongest and highest level of evidence. Now, I completely believe in that, and ready yourself before the next slide. I think that is the strongest and the best level of evidence. But I ask the question, are RCTs a golden standard or a potential golden calf? According to the Bible, the golden calf was a false god, and you can see here a picture by Nicholas Poussin in 1629, where the children of Israel are adoring the golden calf, which was a completely false goal. I'm not saying that RCTs are false. Of course they're not. But we should keep in mind that they are not always practical. Besides RCTs then, we sort of towards the conclusion, what are the alternative methods of evaluating programs? There are alternatives. The one is a review, which evaluates and monitors a program. The basic assumptions are not questions. We don't ask, does toothbrushing work? Do sealants work? We ask whether the program is being delivered. Like in our SMILES program, we ask how many children are actually being taught how to brush their teeth. We do not ask, is the toothbrushing actually preventing caries? Which could and should be asked at a different stage. The program reviews are generally descriptive and not analytic. They do not generalize. We can't generalize from a program review. So if we want to generalize, we can perform a program trial which will or could generalize the knowledge, and here we can ask, is the program effective? Is the effect attributed to the program? For example, we will ask, do sealants prevent caries? The method has to be analytical and needs to be rigorous, but we need to set it up a priori as a test or demonstration. And the control population is very imperative, which leads me to the final slide. How do we find controls in program trials? It's very difficult. It's not easy. We can try and use parallel groups, other communities who have not been not benefited from this program. There are many confounding issues, potentially. We can have an external control, for example, data from other sources. In other countries, we can compare our results to Scotland or the Philippines or wherever. But of course, there are tremendous confounding issues. We can self-control ourselves before and after. Sometimes programs are discontinued, and we can see what happens after they're discontinued as opposed to before, or and if there's any benefit of the program itself. Again, this can often be unethical. There are abundant questions of ethics and confounding issues. So in conclusion, dental caries can and should be largely prevented and managed in programs. The potential methods are simple but potentially and effective. Planners should avoid methodologies which are not evidence-based. As presented by IAPR Gohira as a major challenge, the separation of oral health from general health should be avoided and should not be ignored. Potential obstacles can and should be identified in advance. Programs should be adapted to the needs of local communities, as I said to you right in the beginning when I quoted Fraser and Morowitz. I want to invite all of you to come and be with us in 2 years' time in Jerusalem at the PER meeting in Jerusalem 2016. And I want to thank you for your attention, and I want to thank Colgate for generously hosting this symposium. Thank you.